Well, hi there. I'm Dr. Steve Scionti from Scionti Prostate Center, and today we're going to talk about our experiences in adopting the TULSA-PRO procedure for our prostate cancer patients. Well, just by way of introduction, 6 years ago, when I moved to Florida, I began the Scionti Prostate Center, and in my practice, I'm focused really on treating men with minimally invasive techniques for prostate cancer, specifically prostate ablation techniques. I really had the distinct honor of working with some of my colleagues in New York, where I was the clinical associate professor, urology, and director of the prostate cancer ablative surgery program at NYU Langone Medical Center. And really, that was a great experience because it was really the first truly prostate cancer ablative program in an academic medical center. Once HIFU got approved, we put together a program to make HIFU available to patients around the United States through an organization called Vitero Health, of which I'm their medical director. So over the course of the last 15 years, I've really had the ability to treat over 1,700 patients with prostate ablation utilizing high-intensity focused ultrasound. And over the years, I've treated somewhere around 1,000 patients with cryotherapy. So I was very excited to see another ablative technology available. And we'll talk about how that's been used in my practice and what types of patients I think this creates a unique pathway for treatment. But really, what we really centered on, focused on in our office and in our program is putting the patient at the center of the decisions to treatment. So we do a lot of fusion biopsy and advanced diagnostics, but when it comes to treatment, really the patient really is in the center of a shared decision-making process, which I know that's really what a lot of folks on this webinar would agree with and do in their own practices. So as a really experienced HIFU user, I saw some real differences with TULSA-PRO. So some of the advantages that TULSA-PRO offers is because we are in bore, that is in the MRI scanner, we have advantages we can take of real-time MRI planning, particularly contour planning, which gives the ability to precisely define where the edges of the prostate are or where we want to limit the energy to. I think the strongest and most unique differentiator, though, between TULSA-PRO and HIFU is the MRI temperature monitoring. So we've got precision monitoring of the ablation process, so we can monitor any area, any targeted tissue that we're trying to treat, and watch as the temperature and the thermal doses build in that area. And what's unique with this system that was really different than the HIFU system I used is that there's a lot of robotic automation here, which really determines the amplifier power and basically the amount of time each element is firing ultrasound energy. And it's all based on achieving the desired temperature endpoints at the boundary of ablation. So that closed loop system is really powerful and really unique. The other technical aspect, which I think is really different, is the ability to provide some protection for the urethra. In HIFU, the only way to not destroy the urethra is, frankly, to avoid it. And it's possible to do that with subtotal or focal treatments. The urethra can be avoided. But with TULSA, I have the ability to treat the entire prostate when necessary and provide some protection to that urethra because the urethral applicator is cooled. The rectum is protected in a similar way to HIFU in that there's a rectal cooling circuit as well. As most of you likely know, if you've done any HIFU, we don't have real-time temperature monitoring. We can infer temperature changes indirectly from some tissue changes, but really, we don't have the accuracy of real-time temperature monitoring. And HIFU is very, very, very user dependent. And so as a training director for this procedure, the HIFU procedure for many years, I found it difficult to really help people achieve a lot of confidence with the technique because there is a lot of manual control. To take that process of delivering treatment and automating it, I think is a powerful advantage to TULSA-PRO. I've been highly interested in this approach for several years, and upon the release of the TACT trial data and submission to the FDA and approval for ablation of this device by the FDA in August, we really began to actively put together a program. I'm proud to say we were the first site in North America to perform a TULSA-PRO after the FDA clearance. I had a lot of help putting this together with some of my management colleagues from Vitero Health. And one of the most important things was finding an imaging center which was willing to advance this technology and really invest the time, the energy, and the effort it took to get this established. We'll talk a little bit about that in just a minute. And we've treated 20 patients since January, despite the travel restrictions and the restrictions imposed on our practice by the virus. We've got a busy May coming up. You really want to understand that there's a broad range of disease states we can treat, including extensive low-risk patients, that is low volume disease, multiple Gleason score 6 biopsy sites positive, particularly with urinary symptoms. We can treat both conditions at the same time. Intermediate risk patients who really prioritize sexual function preservation, and very well characterized high risk disease patients. And we'll talk about an example of these in our case reviews. So let's talk about a couple of our cases, just to give you an idea of the variety of patients we treated and how we approached them. Our first case we'll talk about is a intermediate risk patient who has disease localized by both MRI as well as transperineal uronav biopsy to one side. So the treatment strategy proposed was a partial gland ablation, in which we treated, as you'll see, a very generous portion of the prostate. This was not a spot weld treatment or a purely focal treatment. I think treatments that tend to be too focal in nature have a very high risk of incomplete ablation. And my own philosophy is that we do need to treat, if we're going to do a subtotal ablation, treat very wide margins around those known cancer areas. But there was a very specific attempt to spare particularly the neurovascular bundle regions. And we knew from mapping biopsy technique as well as MRI that the right posterior quadrant of the prostate was disease-free. And by maintaining that area non-treated, by preserving that region, we knew we were going to get excellent right neurovascular bundle preservation. So this shows some of the treatment planning. So the and again, when you go through some of the online as well as some of the on-site training, some of these techniques are really pretty easy to do. By the way, I draw all these treatment outlines myself. In my practice, obviously we use radiologists for diagnostic MRIs, but I've been doing both Uronav and Artemis now for a lot of years, and I've always done my own prostate segmentations. So it made sense to me that if I could segment the prostate for biopsy, I could probably segment it for treatment, and I do that. The other thing it allows me to do is it allows me to draw these boundaries in such a way. For example, in the right posterolateral area, I can draw that prostate boundary inside of the capsule so that I'm telling the system to limit the energy in that area in addition. So one of the ways of preserving nerve bundles is really related to how we draw those prostate boundaries. But you'll see in the lower left-hand part of the screen, the thermometry plot, really important because we have a very symmetric plot with really no artifact. The prostate itself has got that blue area. It tells us we're getting really good, strong signal on thermometry. The middle image is a mid-gland segmentation of the prostate, and you'll see the the coronal planes as well. Now, this is an actual image as we're delivering energy. The sectors that are activated, the ultrasound applicator has 10 active sectors or crystals, and this is a small gland, so we're only really using really about 7 of the sectors. We're using E4 or element 4, element 5, element 6, 7, 8, 9. And what we're doing is we're sweeping from approximately the 9 o'clock position. We're sweeping in a clockwise rotation, and you can see that we're not treating the right posterior quadrant. As we're doing this real time, we can adjust this plan on the fly. We can retreat zones. So an area where the index lesion lies, we can resweep that area to achieve a dose escalation in effect. So this gives the urologic ablative surgeon a tremendous amount of control over this procedure. This is the case report that summarizes what we've done. On the upper line, we see the boundaries that we drew. If we look at the actual maximum temperature plots, which are the second line, what you're looking for is yellow. Yellow means that we're in that 58-degree range. The cumulative thermal dose plots, I think, are really helpful because that's an integration of temperature over time, which really determines the ablation efficacy. So if we look at elements 1, 2, and 3, the first apical area that we treated was element number 4, and you can see beautifully where that quadrant of tissue, that posterior quadrant on the right side, has no thermal dose applied. So we know by definition that that right neurovascular bundle has not seen any energy at all. If we also look at the left side, you'll see the thermal dose conforms very nicely to the actual boundaries of the prostate that we drew. Finally, the posterior line, the bottom line, shows our post-contrast images, essentially a verification of what we did. And here, what's impressed me the most about this technology is the actual post-gadolinium images at the conclusion of treatment showing absence of perfusion correspond beautifully to these thermal dose plots. And obviously we know in this patient, the goal was to do essentially a left hemi ablation, do an anterior hockey stick configuration, crossing over to that patient's right side and preserving the right posterior quadrant. And if we look at the gadolinium, post-gadolinium images, that's exactly what we've done. I haven't gotten this patient's PSA back, but he was already having good quality erectile function by 1 month post-procedure. So this was a 3-hour procedure total from the time that we entered the treatment room to the time we exited. We're using total intravenous anesthesia, by the way, in our setting, only because we didn't have the ability to easily exhaust anesthetic gases. And so we made the decision in our center to use a technique with total intravenous anesthesia, which is a little more time consuming certainly in terms of reversal and letting the patient wake up, but it's worked extremely well. Now, case 2, this is a little different treatment. And this is the patient where this will give you a little idea how we approach the patient. I find patients are very visual. And so what I'll typically do is I will draw during their counseling session, I'll actually draw them a series of diagrams about what's the least amount of treatment we possibly can apply consistent with the disease, and what's an aggressive treatment look like, and in terms of how much gland we treat, what are the risks of preserving tissue, or conversely, what are the risks of adding more treatment? So that sort of is a patient-centered approach. But here was the treatment diagram for this patient. This patient had a grade group 2 disease and 7 out of 12 cores. It was confined with targeted biopsy to the right mid to base. It was really the peripheral zone, but the anterolateral peripheral zone. And I've drawn that area there on my diagram as the large circular area with the big arrows to it. There is the area that I wanted the dose escalate to. That's the index lesion. He had multiple cores around that area positive with group 1 disease as well. His left side of the prostate was negative by systematic biopsy, but there's a PIRADS grade 3 lesion that was not biopsied in the left posterior lateral peripheral zone. So the systematic biopsies were negative, but that area was not specifically targeted by the person that did his biopsy. But in any event, we decided to apply treatment there as well. He wanted to be more aggressive. The goal was to preserve a lip of tissue, especially on that left side, around that nerve bundle, as well as the dose escalate around the index lesion. So in this particular study, let's look and see what we did. We look at the top line and see how we drew the curves, the outlines of the prostate. Again, they were drawn in a way that on the left side, we drew the boundary of the prostate really very tight to the prostate capsule. We look at the thermal dose plots, which are the third line down. You can see that on the right side, at the 9 o'clock position, you see thermal dose beyond the prostate. That was intentional. That's an area where we swept that area twice. We drew the margin in that area clearly right at the capsule. We didn't bring it immediately at all. We purposely wanted to get a high dose of energy at that 9 o'clock position, especially in the mid-gland to base segments. So if you look at element E3, or the apical image, you see excellent conformality of the dose to the capsule. But as you get towards E number 5, E6, and E7, mid-gland to proximal base, what you see is you see energy beyond the capsule, and that was purposeful. That's the index lesion. We put additional energy there. Particularly look at the left neurovascular bundle region. We see that there is a little bit of tissue preserved at that 5 o'clock position. So again, this demonstrates that you actually can create a plan for the patient, and with a little bit of practice and thought about this, you can execute that plan. Again, it speaks, I think, to the flexibility of the system. Finally, a third case. This is a patient that had higher grade disease, but it was localized disease. He was a grade group 4, clinical stage T2A. He was diagnosed by MRI targeted plus systematic biopsy. At the right mid gland, he had a PIRADS 4 region of interest. Prostate volume was very appropriate at 40 cc's. PSA was just under 10. And again, this patient had a high degree of importance to maintain sexual function, as well as to treat some of his lower urinary tract symptoms. Although his gland was only 40 cc's, his pre-treatment IPSS score was 16 or 17. The treatment strategy was a whole gland ablation targeting the cancer and the BPH because he was symptomatic, and because we had no documented disease out in the left posterolateral region, purposeful sparing of the left neurovascular bundle. So again, as we go through this series of images, you can see that particularly looking at the second line down, the maximum temperatures achieved, you'll see a lot of yellow and a lot of red on that patient's right side. If you look over towards the left side, particularly between the 3 o'clock and the 6 o'clock position, you see that there's not as much red, which is lower temperatures. But we still treated pretty much right out to that capsule. We just were very careful not to extend energy out near the left bundle. The thermal dose plots, the third line down, really show an area on the right side where you see thermal dose beyond the capsule, consistent with the need to treat higher grade disease. So you'll see that that's an area that we reswept. This patient was retreated between the 11 o'clock position down to the 6:30 position or so. And you can see that reflected in the thermal dose plots, particularly in the midgland and apical regions, E3, E4, and E5, which is exactly where the index high-grade lesion mapped to. And as you look down at the post-gadolinium images, you'll see a lot of loss of perfusion, very pronounced on the right side, extending out to and including that capsule out in the region of the right neurovascular bundle. But if you look at the left side, there's some preservation of the anterior bladder neck towards the base elements. And if you look particularly at the 5 o'clock position, everywhere from apex through base, you see that there is preservation of tissue in the area of that left neurovascular bundle around that 5 o'clock position. So again, our goal was to ablate the high-grade tumor with a lot of energy, essentially treat the whole gland because he had a lot of lower urinary tract symptoms, and spare nerve bundle on the contralateral side, that is left side. So some of the things we learned, it's worth it to spend the time to have a good bowel prep. It's really important to use a consistent team. We've had really the same team involved from anesthesia to nursing throughout this entire process. All the stuff that happens outside of what the urologist does, have that same team consistent, and you got to practice that. We practiced that with the first case we did, first day, 1 case. We moved very quickly on to 2 cases per day. We then only after about 2.5 months, we progressed to 3 cases today, which is where we are today. And eventually I can see some workflow enhancements that will get us to the point where we can do 4 cases in a day, which really helps because you really want to be efficient in that MRI suite. So I think the patients have accepted this extremely well. The patients really get a role in deciding upon and participating with creating their customized treatment approach. The treating physician obviously has got to provide guidance about what's oncologically safe and non-safe, but it has to be a shared decision-making approach. And I like to stress to the patient the range of how I can treat them from a minimal approach to a maximal approach in terms of how much tissue we preserve. And then we talk about, as we preserve more tissue, what are the risks of undetected disease, in non-treated tissue, and so forth. The patients are invested that way in that decision and in their treatment. They own their procedure, which I think is incredibly valuable for them. These patients are amongst the most grateful that I've encountered over my many years of doing this. And they're grateful that at least they have an alternative to standard of care treatment. And it's important that I emphasize to every single patient what standard of care treatment is, and that we are taking an alternative approach. But interestingly, these people get on different patient websites and bulletin boards, and they begin to evangelize. And so at least half the patients I've treated with TULSA to date are referred by their colleagues, friends, and family who've undergone already the procedure. So it's been I think a very rewarding experience for both the patients and for myself. So in conclusion, I think TULSA really offers the urologic surgeon the flexibility to treat a wide variety of patients. You can anywhere from partial to whole gland ablation, low to higher risk patients, patients that can't be treated with other ablative modalities. For example, patients that have anterior lesions, a lot of voiding symptoms, significant BPH, median lobes. And I'll make a comment about that in just a second before I forget, but a very large median lobe, that's the one case where in one particular patient, it was so large that I did elect to take that median lobe down with a vaporization, a button vaporization, a couple of days prior to his HIFU, and he's done incredibly well. But the point is that we have a wide variety of patients. If you're in the ablation space or looking for offering the patients an alternative to their standard approaches, I think this is a very powerful tool that you can adapt across the spectrum of disease. And once you decide the treatment plan, it's the same workflow for your team, no matter what you're doing. It matters just a matter how you're drawing in those boundaries and where you're deciding to resweep the areas or retreat the areas. It's very important that this becomes, with the patient and the physician, a shared decision-making process, because now the patient's completely invested in their treatment and really becomes a partner in their treatment, which I think creates a lot of very grateful and very loyal patients. And I think they're very happy that they went this direction. So I think that concludes our formal comments on our experiences. I would invite anyone on this call to talk to the team at Profound. We're happy to have you visit us either virtually or in person to our clinic and observe procedures, and happy to be a resource for anyone who has any questions. Thank you.